Hi doctor, I've been having a regular headache recently.
Let's do a regular checkup. Your blood pressure is 155/98, which is quite high, so I'll put you on ACE inhibitors.
So, what is an ACE inhibitor?
ACE inhibitors are the most commonly prescribed antihypertensive drug for patients under 55 years old. It is also clinically used for treatment of cardiovascular diseases and diabetic and non-diabetic neuropathies. Several variations of ACE inhibitors are currently available in the market. There are three major classes of ACE inhibitors, which include sulfhydryl, carboxyl, and phosphinyl-containing drugs. Captopril was the first ACE inhibitor to be synthesized. It is characterized by its short half-life. However, the most frequently prescribed ACE inhibitor belongs to the carboxyl-containing group. ACE inhibitors are excreted by the kidneys, therefore dose reduction is essential for patients with kidney failure.
So, how does it work?
Angiotensin-converting enzyme, or ACE, is an important enzyme in both the renin-angiotensin-aldosterone system and kallikrein-kinin system. ACE inhibitors competitively inhibit this enzyme, thus preventing the conversion of angiotensin 1 to angiotensin 2 and stopping the breakdown of bradykinin. First, we will look at the renin-angiotensin system. When kidneys detect a drop in blood pressure, it releases an enzyme called renin from the juxtaglomerular cells. Renin then moves into blood and interacts with angiotensinogen, an inactive enzyme made in the liver, and converts it to angiotensin 1. When angiotensin 1 reaches the lungs, ACE converts angiotensin 1 to angiotensin 2. Activation of angiotensin 2 provokes a number of physiological effects which leads to an elevation in blood pressure. Firstly, it increases sympathetic activation, leading to vasoconstriction and the generation of a higher peripheral resistance. It also stimulates the secretion of aldosterone from the adrenal cortex, which increases water and sodium reabsorption and decreases urine output, thus increasing body fluids and leading to an increase in blood pressure. Therefore, ACE inhibitors were synthesized to competitively bind to ACE, thus preventing the downstream effect and ultimately leading to a decrease in blood pressure. Additionally, ACE catalyzes the degradation of bradykinin in the kallikrein system. When a patient is given ACE inhibitors, it will inhibit the degradation of bradykinin, causing further dilation of blood vessels and reduction in blood pressure. Accumulation of bradykinin increases nitric oxide production, which is responsible for vasodilation in blood vessels.
Can you please tell me some clinical uses of ACE inhibitors?
ACE inhibitors are recommended as the first-line therapy for both hypertensive and non-hypertensive treatment. Their main use is for the treatment of primary hypertension and hypertension caused by renal artery stenosis. Most importantly, ACE inhibitors lower peripheral vascular resistance without compensative increases in heart rate, unlike other vascular dilated drugs. They are used in conjunction with diuretics or calcium channel blockers as second-line or third-line antihypertensive therapy. As for the non-hypertensive conditions, ACE inhibitors are the cornerstone of congestive heart failure and left ventricular dysfunction treatment. For the prevention of diabetic neuropathy, patients with normal blood pressure may also use ACE inhibitors. They can also be used for post-myocardial infarction, atherosclerotic vascular disease, and to prevent heart attacks or strokes. ACE inhibitors may also help to slow the progress of kidney diseases and atrial fibrillation. They can also be used in conjunction with diuretics and beta blockers and digoxin to manage moderate to severe heart failure.
Is it safe to take ACE inhibitors? Can they ACE it?
Yes, ACE inhibitors are generally safe and well tolerated in most patients. However, patients with severe bilateral renal artery stenosis should avoid ACE inhibitors to prevent the development of renal failure. For pregnant women, fetal toxicity is a concern if ACE inhibitors are administered in the second or third trimester. Medications that increase potassium concentrations can also promote hyperkalemia if ACE inhibitors are taken concurrently.
Are there any side effects associated with taking ACE inhibitors?
The most common side effect of ACE inhibitors is dry cough in up to 20% of patients due to an accumulation of bradykinin. ACE inhibitors cause potassium retention due to reduced aldosterone secretion, and other side effects include first-dose hypertension, angioedema, acute kidney impairment, headache, nausea, dizziness, and fatigue. At high doses, ACE inhibitors can cause taste disturbance, neutropenia, and angioneurotic edema. ACE inhibitors can interact with other drugs, for example, non-steroidal anti-inflammatory drugs, angiotensin receptor blockers, potassium-sparing diuretics. ACE inhibitors also interact with antacids by altering their plasma concentration.
So, how does the future look for ACE inhibitors?
Some areas of focus for future studies include the effect of race and ACE genotype on the action of ACE inhibitors, ways to overcome the adverse side effects of ACE inhibitors, their use in preventing cardiovascular disease in those with normal blood pressure, comparison of the efficacy between ACE inhibitors and AT1 receptor antagonists. Other areas of investigation, as suggested by the National Heart Foundation of Australia, are whether ACE inhibitors are underprescribed and underdosed as a first line of treatment for heart failure.